Hello everyone, welcome back. Today we're going to be focusing on sequence of events in acute inflammation. So the sequence of events that we see in acute inflammation. And when we look at this sequence of events, they are divided into two. So we have the vascular changes that we're going to see with acute inflammation. And then we also have the what's going to happen on the cellular level. So in this first part, we're going to focus on vascular changes. And after, we're going to talk about what happened at the cellular level. And as we know, with acute inflammation, this triggers a series of vascular events, and the essence of these vascular events is to allow the immune cells, for instance, our neutrophil and plasma protein, to reach the site of the injury or site of where the infection is. So let's go through the steps in the vascular changes that we see. So the first one there would be the initial vasoconstriction. So if somebody have injury, the first step will be initial vasoconstriction. And this usually is immediate and it normally lasts seconds. And this is mediated by neurogenic reflex, which lead to transient constriction of the arterioles. And also release of endothelin, which is released from endothelial cells. And as we know, endothelin is going to cause vasoconstriction. And because of vasoconstriction, right, that will minimize blood loss immediately after injury. So the reason why we have this in place is to minimize blood loss immediately after injury. So the next step is going to be vasodilation. So that will be the next vascular changes. And this vasodilation is actually the first vascular change that we see in acute inflammation. And this is mediated by histamine from mast cell, basophil, prostaglandin, and bradykinin. And what are these chemical mediators? What are they doing? So they're going to cause vasodilation. So by causing vasodilation, as you know, that will increase blood flow. And because of that increase in blood flow to the site of that injury, so that means the area is going to be red, which is what we call rubor. And of course, the area will be warm because now a lot of heat are moving to that area. So which is what we call calor. And with time, this is going to slow down the blood flow and that could lead to stasis. So the next step there is increase vascular permeability, which is the most important step because when the vasculation become permeable, that will allow those cells and the fluid. So that allows fluid and protein to leak into the tissue because this is very important to bring about repair, to bring about inflammation, so that at the end of the day, repair could occur. And of course, if it's in the case of bacterial infection, this is also very important to be able to facilitate killing of those bacteria. And this occurs minutes to hours after injury has occurred. So let's see what are the process that facilitates, that makes this capillary permeable. So one there, the first one there is endothelial cell contraction. Because when you look at the blood vessel, right, so we have the endothelial cells lining those blood vessels. And of course, inside those blood vessels, that's where we have our what? We have our white blood cells, right? And we also have our inside the plasma, we have those protein, guys. We have those protein. So the endothelial cell is going to contract. So once the endothelial cell contracts, that creates a space in between them. And then once you have a space, then that will allow those fluid to be able to live in between the what? In between those endothelial cells. So endothelial cell contraction creates reversible gaps. And this mainly happen at the post-capillary venules. It's important for us to know that location, post-capillary venules. So that's one way. The other way is the direct endothelial injury. So for instance, in the case of burns, toxin, or severe infection, instead of contracting those endothelia, they could be destroyed directly, and that will lead to post-capillary venous permeability. Next is leukocyte-mediated injury, whereby when the neutrophil is activated, and those neutrophils, they're going to release reactive oxygen species, and those reactive oxygen species, they're going to damage the endothelial cell, and that will also lead to vascular permeability. And if you look at this process, they are mediated by histamine. So histamine causes endothelial contraction, bradykinin that increased gaps, leukotriene, and substance P. And of course, like we mentioned, this will result. So once the vascular become permeable, then we're going to have exudation of protein-rich fluid. So those fluids are going to move out into the tissue or interstitial space, and that will lead to swelling, which is what we call what? Tumor. And of course, with time, that could lead to formation of fibrinoid exudates. And the next step there is going to be stasis and margination. So with loss of plasma, then the blood become more viscous, and that now allow the blood to slow down. So blood flow slows down, and then that allowed the leukocyte to move to the wall of the blood vessel, which is what we call margination. So those leukocytes now, they're going to be able to move towards what? The wall of those blood vessels, and that's what we call margination. So leukocyte marginates and move to vessel periphery, and this prepare the leukocyte for what we call leukocyte extravasation. So leukocyte extravasation is the process whereby the leukocyte is going to leave the blood vessel and go to the tissue or the site of the injury or where the bacteria is. And the last step there is endothelial activation. So this endothelial activation is mediated by cytokine, and we have to remember these cytokines, very high yield. And what are these cytokines? These are same acute phase cytokines, so interleukin-1 and TNF-α. So this interleukin-1 and TNF-α, they will stimulate the endothelial cell. And once they stimulate the endothelial cell, that will express selectin, which is important for leukocyte rolling. They're also going to express ICAM1 and VCAM1, which are important for adhesion. And the endothelium becomes procoagulant, and that leads to local thrombus formation. That's why, if you guys remember, Vascular triad, and what's Vascular triad? So this triad is what predisposed towards formation of blood clots in the body or thrombosis. So anything that affects any of these triad is going to lead to what? Thrombosis. And what are the triads? So the first one is what? Stasis. Second one is what? Endothelial injury. And the third one is hypercoagulability. And that's why in the case of injury, right? In the case of injury, it can lead to stasis and it can lead to endothelial injury. So that's why those patients could also be predisposed to what? Blood clots. They could be predisposed to thrombosis. So now we've completed what happened in the vasculation, so vascular changes. But now we're going to focus on leukocyte changes. And this leukocyte changes is also leukocyte extravasation. And what's leukocyte extravasation? So extravasation means leaving the blood vessel. So this is the process by which leukocytes move from the bloodstream into the inflamed tissue. And it mainly occurs in the post-capillary venous, that same location we mentioned earlier. So neutrophils are the primary leukocytes in acute inflammation, and that extravasation occurs at the post-capillary venous. So again, if you look at this picture, so here we can see our blood vessel, and inside the blood, lining the blood vessel, we have the what? We have the endothelial cells that are lining those blood vessels. So we have our endothelial cells. And let's say this is the site of the tissue, and then maybe at the site of the tissue, maybe there is a bacteria there, or there is a what? There's an injury there. So, but for the purpose of it, we can use what? We can use bacteria. So, what's going to be the first step in order to move the leukocytes into the site of the tissue? Because the leukocyte is inside the blood vessel, and our goal is to move our leukocytes, our neutrophil, from here and move it to the site of the injury. So the first step there is going to be margination. So they have to move to the margin. So this white blood cell is going to move to the margin. So margination is the process where the leukocyte move from the center of the blood vessel towards the endothelial lining during acute inflammation. And there are two forms of neutrophil that we have. So they are divided into two. So we have what we call the circulating neutrophil. So those are the neutrophil that are circulating. They are not bound to any adhesion molecule. And then we also have what we call the marginating pool. So those marginating pool of neutrophil, those are the neutrophil that they are attached to the adhesion molecule. So when you look at them, they are bound to the what? Adhesion molecule. So those one we call them what? We call them marginating. And every time you do a complete blood count, what we normally count is the circulating pool of neutrophil. So that's what we normally count. And that's why if somebody is taking medication like corticosteroid, so like steroid, so this corticosteroid normally inhibits adhesion molecule. So by inhibiting the adhesion molecule, that means this white blood cell, instead of it being marginating, is going to become what? Circulating. And then remember, like I mentioned earlier, anytime you do complete blood count, what we are counting is the circulating neutrophil. So that's why if somebody is on corticosteroid, they're going to have what? Neutrophilia. So their white blood cell, they're going to have increase in white blood cell. And the reason why their white blood cell is increased, is because this bound or marginating neutrophil has become what? Circulating neutrophil. And who can also remind us what's also the other effect of corticosteroid on the blood cell? Very good. So if somebody is on corticosteroid, what's up to eosinophil? Very good. Eosinophil will be what? Decrease because of apoptosis and sequestration of the eosinophil in the lymph node. What about the lymphocyte? Very good. Lymphocyte is also going to be what? Decrease because of apoptosis of the lymphocyte. So that means if somebody is taking corticosteroid, eosinophil is going to be decreased because of increased sequestration and apoptosis, and lymphocytes will be decreased because of increased apoptosis. But neutrophil is going to be increased because of demargination. So those neutrophils, instead of them being at the margin, they are being demarginated, and now they become what? Circulating pool. So moving on. So now what's going to happen in this case? So in acute inflammation, so there's going to be release of what? Acute phase cytokine. Remember, we mentioned this earlier in the past. So this acute phase cytokine, particularly interleukin 6, is going to stimulate the liver to make acute phase protein. And one of those acute phase protein is fibrinogen. So this fibrinogen now is going to be coating the red blood cell. So once we have our red blood cell, inside the blood vessel. So those fibrinogen now are going to be coating the what? They're going to be coating the red blood cell. And as they are coating the red blood cell, that's going to remove the negative charge on those red blood cells. And then once you remove the negative charge on those red blood cells, or once you decrease the negative charge on those red blood cells, that will allow those red blood cells to what? Aggregate together. And then once they aggregate together, we call them what? Like a Rouleau's formation. And remember, the more aggregation, the more inflammation you have, the higher the interleukin 6, the higher the fibrinogen, the more red blood cell is going to aggregate. And then remember, as they aggregate together, like we mentioned in the previous lecture, that will increase their density. So that will increase their density. And then when you put them inside a test tube, a vertical test tube like a pipette, when you put them there, they're going to what? They're going to fall faster. And what do we call that? Very good. Erythrocyte sedimentation rate. So the longer the inflammation, the more likely they're going to forward faster. So because of this rouleau formation, then that will now push the white blood cell, right, to the periphery of the blood vessels. So that will push them out. So as you can see there, so the rouleaus mechanically forces the neutrophil out of the central acid stream and push them to the peripheral. And that's what we call margination, guys, margination. And remember, we mentioned earlier, because as you lose plasma, what happens? Remember, we said that there's stasis of blood, and that also facilitates what? Margination. So the next step there is going to be rolling. So now that the neutrophil has marginated, so now they need to roll to the wall of the blood vessel. So for them to roll to the wall of the blood vessel, what do we need? So like we said, rolling is the process where neutrophils slowly roll along the endothelial surface instead of flowing freely in the bloodstream. And then for rolling to take place, so what do we need? So we need selectin. So they are selectin mediated interaction. So rolling is primarily mediated by selectins on the endothelial cells. So we have E-selectin, P-selectin. So this E-selectin is on the endothelial cells. Both of them, both E-selectin and P-selectin, both of them are on the endothelial cell. And this E-selectin is induced by our acute phase cytokine. Remember, we saw that earlier, that those acute phase cytokine, they induce the selectin. And this P-selectin is stored in Weber palate body. And of course, it's rapidly mobilized out of them and released, ready to be used. And then what are they going to do? So this P and E selectin that is on the endothelial cell, they're going to bind to cilia Lewis on neutrophil. So on neutrophil, we have what? We have our cilia Lewis, and that's what they're going to what? Bind to. And then once they bind to it, that's what allowed them to what? To roll. Very good. And then the other thing we also have is also the glycan 1, which and a CD34. And then both of them are adhesion molecules on the endothelial cell that function as ligands for L-selectin on the leukocyte. So this one are going to be binding to the L-selectin on the leukocyte. And of course, if there's a problem with this guy, that will lead to what? That will lead to impaired neutrophil recruitment. And that's why we have to do a chemical correlation here. So there's a disease whereby if you have problem with your S. Lewis, guys, if the S. Lewis is affected, if there's a deficiency of it, so that means that will lead to defect or problem with what? Rolling. And as we mentioned, this S. Lewis is the ligand for our E-selectin, right? So that's what the E-selectin is going to bind to. So neutrophil cannot roll properly due to defective of S. Lewis, leading to recurrent infection. So remember, in leukocyte adhesion deficiency type 2, right, is due to the deficiency of S. Lewis. And the way I remember is S like a secondary or like a second. So that's why I know that that's affected in leukocyte adhesion deficiency type 2. So now let's say no problem. Let's say rolling was able to occur. So it's able to roll. So our white blood cell is able to roll to the wall of the blood vessel. So now after rolling, what's going to be the next step? So now that they are the periphery, so the next step is going to be tight binding. So they have to bind to the wall. So the next step is going to be tight binding. So neutrophil adhesion to endothelium. So what's the mechanism? So neutrophil is going to express integrins. So for here we need what? Integrins. So neutrophil express integrins on their surface. So we have the LFA1, which is lymphocyte function associated antigen 1. And the CD marker for this one is CD11A and CD18. And then we also have the MAC1, which is macrophage 1 antigen. And the CD marker for it is also CD11B. So instead of 11A, this one is 11B and CD18. And then what do we have on the endothelial cell? So on the neutrophil, that's what we have on the neutrophil. What about on the endothelial cell? So on the endothelial cell, we have our ICAM1 and BCAM1. So ICAM1 is intercellular adhesion molecule 1, and the CD marker for that is CD54. And on the VCAM1, that's vascular cell adhesion molecule 1, and the CD marker for that is CD106. And as we mentioned earlier, these are all regulated by the help of what? Our acute phase cytokines, so interleukin 1 and TNF-α. And this will allow them to be able to what? Adherent to the wall, what we call tight binding. So neutrophils stop rolling and adherent tightly, and it's going to now prepare for what? Migration, which is what we call diapedesis. So what about if somebody have problem with their integrin, which is what we call leukocyte adhesion deficiency type 1. So they have to be type 1. So the way I remember, like integrin looks like 1. So type 1. Remember, S. Lewis is going to be what? Type 2. But integrin is type 1. So defect in beta 2 integrin, whereby the CD18 integrin deficiency. And this leads to what? So what are the problems we're going to see? So that means the neutrophil cannot bind to the wall. It can't adhere to the wall. So that means we're not going to have any marginating. There will be no marginating what? If we go back to our diagram, there will be no marginating neutrophil. So that means all our neutrophils are going to be what? Circulating. So that's why those patients are going to have what? Very good neutrophilia. So they're going to have neutrophilia. And then we can't get neutrophil to the site of where the bacteria is, because the neutrophil will not be able to leave the blood vessel to go to where the bacteria is. So that means these patients are going to be having what? Recurrent infection. And then when you look at the site of the infection, what's going to happen? You're not going to see inflammation there. So there has to be absence of what? Pus, because you can't get neutrophil to where the infection or bacteria is. So what are the clinical clues? So recurrent bacterial infection, delay in umbilical cord separation. Because when you cut the umbilical cord after delivery, right, what happened? Remember, our body response to injury is inflammation. So inflammation are supposed to happen, and that inflammation is what's going to allow the umbilical cord to separate. But if you cut it and inflammation does not occur, then that will lead to delay in umbilical cord separation. And then when you look at the site of where the bacteria is, there to be absence of pus formation, because neutrophil cannot get to that site. And of course, because all the neutrophil, they can't adhere to the wall, they are all in circulation, then that will lead to what? Neutrophilia in those patients. Very good. And then, like I mentioned earlier, corticosteroid, catecholamine, they inhibit what? Adhesion molecule. So by inhibiting adhesion molecule, that means the normal marginating pool will become what? Circulating pool. And that will lead to increase in peripheral neutrophil count because of demargination. So they're going to have neutrophilic leukocytosis. And that's why if somebody is having things like seizure, right? So with seizure, remember it's a form of catecholamines, right? So a lot of catecholamine will be released. So that's why when those patients come in, they could have neutrophilic leukocytosis. That doesn't mean that they have infection. It's just because of what? Of those demargination. Same thing if somebody is on corticosteroid, they could also have neutrophilic leukocytosis. That doesn't mean that they have what? Active infection. It's just because of what? Demargination. And one of the things that to look for, you can look for immature neutrophil, like what? Like bands. So if there's no bands, that means this is likely what? Demargination is not infection. So now let's say tight binding was okay. The neutrophil was able to bind to the wall. So what will be the next step? So the next step is going to be what? Migration. So the neutrophil has to migrate out in between the what? Endothelial cell. So the next step is going to be migration. And that migration is also referred to as what? That transmigration is also referred to as diapedesis. So the next step there is going to be neutrophil transmigration. And that neutrophil transmigration is also what we call diapedesis. So that will be the next step. So the process by which neutrophils squeeze through the endothelial cell into the tissue during acute inflammation. And what are the mechanisms? So neutrophil moving along the venular endothelial cell dissolve the venular basement membrane, and it's going to release type 4 collagenase, because it's going to use that collagenase to be able to dissolve those basement membrane. Exposed by previous histamine mediated endothelial contraction. Remember, I mentioned the endothelial contraction that's being done by histamine in the vascular changes, and enter the interstitial tissue. And of course, as they go into the interstitial tissue, what was going with them? Very good. So plasma-derived fluid rich in protein and cell, which is what we call exudate, is also going to accumulate in the interstitial tissue. And then remember, in this protein, what I think that we're going to have, one of the things we're going to have there is our what? Opsinin. Very good. Example like our IgG and C3b are also going to be present in those fluid. And then what mediates this transmigration? So this transmigration is mediated by platelets endothelial cell adhesion molecule 1, and which is PECAM1. So that's what's going to be present on the neutrophil, and that's also what's present on the endothelial cell. And the CD marker for that is CD31. So CD31 for both of them. So what's the function of this exudate? So it dilutes bacterial toxin if they are present. And then remember, like I mentioned, they contain what? Opsinin. Because opsinin is important to coat the bacteria so that it can facilitate phagocytosis. And then what are those opsinin? So IgG and C3b, right? Remember, our C3b is from the complement system. So that's one of the products from the complement. So now, after transmigration, so now they out of the what? Now they are out of the blood vessel. So now we have our white blood cell out of the blood vessel. So now they need to move to where the bacteria is. And that process is what we call migration. So they need to migrate to where those bacteria are located. And that migration is guided by what we call, that's also what we refer to as neutrophil chemotaxis. So the definition, so directed migration of neutrophils towards the site of infection or injury along a chemical gradient. And the mechanism, so the neutrophils follow a chemical gradient that lead to the infection site. And this is chemotactic mediators bind to the neutrophil receptor. And then once those chemotactic binds to the neutrophil receptor, they facilitate the movement of that neutrophil towards the site of the injury or the bacteria. So what are these endogenous mediators that are involved in this process? And this, we have a great mnemonic to be able to remember them. So that's our click PN. So click PN. So what does C stand for? So C is C5A from complement system. L is LTB4 from lipooxygenase pathway. I is interleukin 8, which is a part of chemokine. K is kallikrein from kallikrein kinase system. P is platelet activating factor, which is produced from neutrophil, platelets, endothelial cell, mast cell, and monocyte. And the last one there is exogenous, the exogenous source, which is going to be the bacteria product, which is N-foamy methionine peptide. So these are all our neutrophil what? Chemotaxis. So the first, the few one there, the C5A LTB4, interleukin 8, kallikrein, platelet activating factor, those one they are what? Endogenous mediator. Whereby the last one, which is our N, which is N-foamy methionine peptide, that's from the bacteria products. And this chemotactic agent, they bind to the GPCR, which is G protein coupled receptor on the leukocyte. And the binding causes the release of calcium and that increased neutrophil motility, guys, so that the neutrophil could move towards the site of the injury or where the bacteria is. And then, guys, we've come to the end of today's lecture. In the next lecture, we're going to be talking about opsonization, phagocytosis, and killing of the bacteria. And then remember, there are two forms of killing. We have the oxygen dependent and the oxygen independent killing. And of course, there are a lot of diseases that could affect that process if something goes wrong. So don't forget to subscribe and put on the notification bell. So when that video is uploaded, you're going to be the first one to receive the notification. So as always, we're going to do some questions. So the first question there, a patient with acute bacterial pneumonia develops localized swelling and protein-rich fluid accumulation in the alveoli. Which vascular mechanism, so vascular mechanism is primarily responsible for this process? So like we mentioned, that's going to be the histamine, causing endothelial cell contraction, thereby increasing intercellular gap between them, and that will allow those exudate fluid to be able to move into the tissue. Very good. Next question. Which mediator is responsible for immediate but short-lived increase in vascular permeability during acute inflammation? So like I mentioned earlier, this is going to be our histamine, guys. Next, during acute inflammation, slowing blood flow causes leukocytes to move towards the vessel wall. This phenomenon is known as, remember, that's what we call what? Margination, right? So that's when the neutrophil is moving to the periphery. So that's what we call margination. Next, which cytokines are most important for endothelial activation and increased expression of adhesion molecule during acute inflammation? Remember, these are our acute phase cytokine, particularly interleukin-1 and TNF-α. Remember, those interleukin are also responsible for what? Particularly interleukin-1 is responsible for fever, whereby our TNF-α normally mediates what? Shock. Next, a 6-year-old girl has recurrent bacterial infection, and then look at there's absence of pus. So there's no pus, even though despite the bacterial infection, there is no pus at the site of the infection. And then when we do our labs, there is a persistent neutrophilia. So this tells me that there's a problem with what? This patient likely have what? Leukocyte adhesion deficiency. So which step of leukocyte extravasation is most likely defective? So that would be what? Farm adhesion. So this is a problem with adhesion deficiency. Remember, there are two of them. We have the adhesion deficiency type 2, which is due to defect in what? S. Lewis. And we also have type 1, which is problem with integrin. Very good. Next, a neutrophil exits a post-capillary venous by squeezing between the endothelial cell. Which molecule primarily responsible for this process? Remember, that molecule is what? Our PECAM1, which is CD31. And this is present on both the endothelial cell and the leukocyte. Very good. Next one. Which mediator is most important for directing leukocyte to the site of tissue injury after they exit the blood vessel? So they're asking us for what? Our neutrophil chemotaxis, guys. So remember C5a, LTB4, interleukin-8, kallikrein, platelet activating factor, and N-methyl, right, peptide. So the best answer there will be what? Will be interleukin-8, which is D. Next one, in acute inflammation, leukocytes primarily exit the circulation at which location, right? Remember we said post-capillary venules. That's where they go to exit. Next question, a 2-week-old newborn is evaluated for inflammation of the umbilical cord, which is omphalitis. The umbilical stump has not yet separated. The infant has a history of recurrent skin infections with Staphylococcus aureus, but no purulent discharge is noted. Lab study review markedly elevated neutrophil counts. Which of the following cellular defect is most likely cause this condition? So delay in separation of umbilical cord or inflammation of the umbilical cord with recurrent staph infection. And now we've seen there's no pus at the site of the infection, and we see a lot of increase in neutrophil in the circulation. So we see um, um, neutrophilia. So this is most likely what problem with integrin, guys, on the leukocyte. So the best answer there would be what? C. So this patient likely have leukocyte adhesion deficiency. Um, and the last question there, which laboratory finding is most characteristic of leukocyte adhesion deficiency type 1? So like we mentioned, they're not going to have marginating pools of neutrophil. All their neutrophil are going to be what? Circulating, and that will lead to what? Neutrophilia. Thank you guys for watching. Please don't forget to like, subscribe, and follow us on our social media platform. And I will see you guys in the next lecture. Bye.